Good evening. Assalamualaikum warahmatullahi wabarakatuh. Welcome to this Indonesian Society Interventional Cardiology Distant Learning Session. I'm Dr. A Fauzi Yahya, and it is my pleasure to moderate today's program. Thank you to Concept Medical and Lumina Rifas Group, which support this webinar. Dear colleagues, as an interventional cardiology, we continue to face complex lesions, small vessel, ISR, bifurcation, and patients who are not always ideal candidates for stent-based strategies. This is where drug-coated balloon treatment have become highly relevant in this contemporary PCI practice. In our country, more and more interventional cardiologists performing DCB angioplasty, either as pure DCB angioplasty, which is no metal cage inside the vessel, or hybrid procedure, which is DCB was used to minimize stent length or avoid to put two stent in bifurcations. So, dear colleague, at first glance, performing DCB angioplasty may look simple: inflate the balloon, deliver the drug, and finish the case. But in reality, there is a strong scientific foundation behind it. To achieve durable result, we must understand the biology, the pharmacology, the vessel response, and the technical nuance. Otherwise, the outcome may not be successful. Recognizing the growing potential of DCB therapy in coronary intervention, ISIC has been committed to advancing knowledge in this field by organizing comprehensive seminars and hands-on workshops featuring national experts and world-class masters who generally share their expertise with our members. Today's webinar, we will explore the role of sirolimus-coated balloons with a focus on tip and trick for optimal preparation and treatment strategy. We are delighted to have two distinguished speakers. The first speaker is Dr. Wishnu Aditya. He is an interventional cardiologist from Jakarta Center. Dr. Wishnu actively involved in ISIC's national training program and regional collaborations. He is among our interventional cardiologists who represent Indonesia in international intervention forums. So how are you, Dr. Wishnu? I hope you are doing well.
All good, Dr. Fauzi. Delighted to be invited. Thanks a lot.
Thank you to your dedication in assisting as our society. So Dr. Vishnu is going to talk about DCB overview and mode of action. The next speaker, it is my pleasure to introduce my friend, our esteemed guest speaker, Professor Dr. Bernardo Cortese. Dr. Cortese, it is wonderful to see you again.
It is as well.
Yeah. Thank you for your accepting our invitation and for your willingness to share your experience and expertise with us.
My pleasure. And thank you for having changed the time, but 4 a.m. would have been a little bit difficult for me to join you. So thanks a lot. I'm really, really, really happy to be here.
Yeah, we are great to have you. Dr. Cortese is an internationally recognized interventional cardiologist and true pioneer in drug-coating balloon therapy. He served as the editor of leading DCB books. I read your books, Dr. Cortese, at the 2019 at that time, the COVID era.
Yes.
Very wonderful book. I read that 3 times, the books. I finished all them. Yeah, because this is really insightful.
Thank you.
And
thanks a lot.
Yeah, Dr. Cortese has led several landmark studies, including EASTBORNE registry. His contributions have significantly shaped the evidence base for DCB use, optimization strategy, and long-term clinical outcomes. And Dr. Cortese is not a stranger to us. He joined ISICAM in 2023 as faculty, performing live demonstration and delivering several impactful lectures. He also visited our center in Bandung for a dedicated DCB workshop, where he performed live cases and shared hands-on insight with our teams. Today, Dr. Bernardo will present the result of the EASTBORNE study and share his valuable insight, including practical tips and technique for successful DCB angioplasty. Dear colleague, we are having 3 esteemed panelist colleagues. First, Dr. Sodiqur Rifqi, who is now serving as the chairman of ISIC. Dr. Rifqi, how are you?
Hey, fine, Dr. Rodi. Thank you so much.
Yeah, it seems that you are now getting more and more busy. And I heard that you just finished ISIC core meeting. Thank you for your taking time to be with us today.
Okay, thank you so much, Dr. Fauzi, for involving me in this wonderful meeting.
And other colleague is Dr. Dasdo A Sinaga. He's a very active interventional cardiologist who is also a top marathon runner. And now acting as organizing committee chairman of ECCAM 2025. So despite your busy schedule as the OCO chair of the ECCAM 2025, you have taken time to be here with us today. We truly appreciate Dr. Dasdo.
Thank you for inviting me. It's a pleasure of mine. Thank you, Dr. Fauzi.
Yeah. And the last of our panelists is Dr. Dewa Sumajaya, Rising Star Interventional Cardiologist. Now you work at the Bali International Hospital, right, Dr.?
Yes. Hi, Dr. Fauzi. How are you?
Yeah. Thank you very much for being with us.
Yes, thank you for inviting me in this wonderful meeting.
Thank you, dear colleague, this session will run for 90 minutes. I invite all participants to submit questions through the Q&A box. We are happy to have the best doctor in DCB in this evening meeting. Without further delay, let us begin. I invite our first speaker, Dr. Wishnu. The floor is yours. You have 25 minutes, and after that, we are going to have discussions. Please, Dr. Wishnu.
Great, thanks. So I hope you can see my screen now.
Yeah.
Start presentation. Okay. I get the presentation is on now. Can you see my slide? Yes, okay.
Yes, I can see it. Very wonderful.
So good day. It's a pleasure to be here and looking forward to learn and discuss about DCB with all of the experts here. My name is Wishnu from Jakarta Heart Center, Indonesia, and today I'm going to talk more of basic science, and this is about the principle of DCB, the options you have, and also the use case scenarios. So first of all, as an introduction, DCB is not a magical healing device. Rather, the process is opening the lumen by force, inducing injuries, then preventing part of the healing process in order to keep the lumen open. So rather than a healing device, DCB actually prevents part of the healing process. And this is how to illustrate it. Just imagine you have an atherosclerotic lesion. Then you open it by force doing a this is the image post-predilatation. Then if you do only a balloon and you leave it alone, sometimes you can have an uncontrolled healing proliferation. And this process is similar to a scar processing after a wound. So therefore you can have even a narrower lumen after you do a predilatation. But if you do apply DCB, the hope is to have a controlled healing, and therefore you can have a bigger lumen after that. So this is the outline of today's presentation. And now let's start from the first one. It's about the normal cell proliferation cycle. So this is the normal cell proliferation cycle. It started from G0 phase. This is the resting cell cycle where the cell is not trying to proliferate. Then the G1 phase, this is the preparation phase for DNA synthesis. It will synthesize proteins and RNAs. And there will be a G1S checkpoint. If you pass the checkpoint, then you will move to the S phase. If you don't pass the checkpoint, then the cell will return to G0 or resting phase. And the S phase is the synthesis phase where the DNA replication occurs, doubling the genetic material. And the G2 phase, it is where the further cell growth and mitosis preparation and the synthesis of tubulin for microtubules. And after that, the M phase is where the really cell division or mitosis occurs, and there will be 5 subphases of mitosis. And in the 5 subphases of mitosis, I want us to focus on this phase, the metaphase. This is where the spindle fibers appear. So the spindle fibers will start from the centrosomes, attaching to the chromosomes. Then it will pull chromatids or half the chromosomes apart by elongation and shortening of spindle fibers. Then the chromosome will arrive at opposite poles, then the spindle fibers will disassemble. So you can think the spindle fibers like a railway tracks in the cell. Now let's look at the sirolimus and paclitaxel and also their effect on the cell proliferation cycle. So paclitaxel is a cytotoxic agent. It works on M phase of the cell. It stabilizes the microtubules and it will prevent tubule disassembly during mitosis. This drug is widely used as a chemotherapy, and the structure is dominated by a nonpolar region. Therefore, it is highly lipophilic. So to illustrate that, the paclitaxel will inhibit depolymerization. Therefore, the spindle fibers cannot disassembly, and therefore the cell will be arrested in a metaphase and a phase transition, causing a mitotic catastrophe. And after that, the cell will activate an apoptotic pathway through the intrinsic and extrinsic pathway. The second drug is, of course, sirolimus. This is an immunosuppressant drug, works on M phase of cell cycle, and works by inhibit mTOR pathways. The primary medical use is to prevent the prevention of organ transplant rejection and also management of vascular cell tumors. The structure is dominated by polar region, and therefore it is more hydrophilic. And again, to illustrate this, in G1 phase, there is a very important pathway called the mTOR. And by applying sirolimus, it will bind to the FK binding proteins, and this complex will inhibit the mTOR, and therefore will put the cell on G1 arrest. And the easier way to illustrate this is by imagining this all as a war strategy. So for example, let's call the G1 phase the executive planning phase, the S and G2 as the supply preparation phase, and the M phase as the troops factory. If you apply paclitaxel, it's like applying doing a bomb drop, and therefore you will destroy the factory in production, but you will also have a more collateral damage in doing so. And sirolimus is like performing a spy attack on the executive planning phase. It will stop the production before it started. Therefore, you will have less collateral damage. Now, human has many cell types. If you applying a cytotoxic or cytostatic agent, which ones are the most affected? Well, cytotoxic and cytostatic agent primarily will target rapidly dividing cells. So cells like cancer cells, hair follicle cells, endothelial, PSMC, immune cells, and bone marrow cells will be more affected. And these three type of cells, endothelial, PSMC, and immune cells, is blood-related, vessel-related cells, and therefore will be more connected for us in doing coronary and or also vascular intervention. Now, atherosclerotic lesion is more complex than a usual blood vessel cells composition, because other than PSMC, endothelial, and immune cells, it also has components of calcium, fibers, and also lipid. If you giving paclitaxel, then it has a higher toxicity, and it will affect broader range of cell effect. So more effect on calcium, fibers, lipid. And if you're giving sirolimus, that agent is less toxic, and therefore you will also have less range of cell effect. It is more selective to FPSMC, and also it also has a more anti-inflammatory effect. So now let's move on to the third point. This is about DCB pharmacology and delivery system. Now you have heard in depth about sirolimus and paclitaxel, but these are the other factors that determining the outcome of our cytotoxic or cytostatic medication. And these three factors are the lesions, drugs, and delivery system. If you talk about lesion, then you can have many more variables. For example, your lesion might be calcified lesion, simple lesion, fibrous lesion, or vulnerable plaques, or containing thrombus. If you talk about the options of your medication, you can have paclitaxel, sirolimus, and the other limus that is developed, like biolimus or sotorolimus. And also you can have many options of delivering the drug. For example, you can deliver it by stent base, by balloon base, you can give it intravenously or even orally. And the combination of these factors will determine the outcome. Now, let's see at our standard practice of delivering the drug by drug eluting stent. the lesion is scaffolded and there will be a sustained drug release because the drug will be released by polymers or stent groups over time. And in the setting of DS, actually, the debate between sirolimus and paclitaxel is pretty much over, actually, because this is one of the latest paper. This is about meta-analysis of 16 randomized trials in sirolimus eluting stent versus paclitaxel eluting stents. The sirolimus stents are superior to paclitaxel in terms of re-intervention and stent thrombosis. While there is no difference in mortality, there is a trend to higher MI risk with paclitaxel. And because of these reasons, we don't see this paclitaxel stents anymore. Now everything is limus-based. Now let's do a comparison between DS versus DCB pharmacologically. If you put DS, then the drug delivery will be more sustained. It's within weeks to months. While if you're doing DCB, then the drug will be delivered rapidly within seconds to minutes. And how about the drug retention in tissue? It's a little bit inverse. So if you're giving a DS, actually the sirolimus is more prolonged than paclitaxel. Sirolimus is about 30 to 90 days, by paclitaxel is only up to 30 days. But in DCB, sirolimus is shorter. Sirolimus will be retained in cells in about 7 to 14 days, while paclitaxel is 14 to 30 days. And also there's a different effect on endothelization. If you put a DS, then there will be a delayed endothelization. And while you're doing a DCB, there will be a faster endothelization. The DS is delayed because because the endothel has to cover up all the polymer and metal and so on. Now let's talk about pharmacodynamics in DCB setting. And there are two main things that we need to note. The first one is lipophilicity. That means it's easier to penetrate cell walls because cell walls contains lipid. And the second one is hydrophobicity, and that means hates water. And therefore, if you give a drug, it will be less likely to be diluted in transfer. Well, paclitaxel is quite ideal for DCB because it has good properties. It's both lipophilic and it's both hydrophobic. While sirolimus also have both of those properties, but it is not as strong as paclitaxel. And then there is the role of excipient, and excipient means substance that will be used to deliver the drug. And excipient can act as a delivery system and potentiator of the medication. And there are a lot of DCB brands nowadays, and everyone is developing their own excipients. And this is what probably can make or break your DCB, whether you can develop a good excipient or not. And lastly, let's talk about evidences and also clinical recommendations. So the clinical trial, because DCB just recently having boom around probably in the last 5 to 7 years, then you don't see lots of big RCTs. For example, this is a small RCT for de novo coronary lesions. So only contains about 70 samples. But in the small trials, it was seen that the novel sirolimus is actually angiographically non-inferior than sequent paclitaxel in de novo lesions. But the other trials, this is the Transform-1 trial. It's about the lesions in about the using of different DCBs in small vessel disease. It shows that in sirolimus is actually in this trial failed to achieve non-inferiority for angiographic net gain at 6 months. But again, paclitaxel is also not perfect. For example, this is the case report about the developing of coronary artery aneurysm post-drug-coated balloon angioplasty in ACS patients. And therefore, you can see the effect of toxicity of paclitaxel. It might also not be good if you're using in acute phase. This is a meta-analysis that was published in about 2024. And it's not a big meta-analysis because it's also not based on big RCTs. So the sample was about 1,861, 5 randomized trials, 3 observational. Then this is a result comparing about target vessel failure, and this is the result comparing MLD and follow-up angio. And the conclusion was the risk of TPF was similar during 9 to 12 months of follow-up, but the MLD was larger, favoring paclitaxel coronary balloon on follow-up angio. And this is the latest meta-analysis just released 4 days ago in Circulation American Heart Association. So this is comparing paclitaxel DCB, limus-based DCB, DES, and also POBA. So this meta-analysis contains 39 randomized controlled trials, contains of 10,219 patients with the primary outcome is MACE. But we should note that not all the randomized controlled trials is actually built for either DCB or to compare between DCB or compared between DCB and DS. So this is a bit a mixed meta-analysis. But the conclusion was there was no significant difference in MACE between Limus and paclitaxel-based DCB, and no difference in MACE between Limus DCB, paclitaxel DBC, and new generation DS. But everything, both of the type of DCBs and DS are all better than POBA alone. And this will be my personal case-by-case approach in choosing DCB type based on the limited evidences. So for a simple de novo lesion, I think it will be no problem choosing between sirolimus and paclitaxel. If you have a small vessel disease, I would rather choose paclitaxel because from small trials, sirolimus failed the non-inferiority criteria. If you have a limited lesion expansion, I will choose paclitaxel because it will give you a better late luminal gain. If you have a calcified, heavily fibrous plaque, also will choose paclitaxel because it has a broader cell effect. If you have SES case, I'd rather use sirolimus because it has more anti-inflammatory and less toxicity. If you have vulnerable plaque, I would also use sirolimus because it is less toxic and more anti-inflammatory. And if you ever had a difficult device delivery or you think it will be difficult, I will probably choose paclitaxel because it's more hydrophobic. Therefore, it can tolerate being in the transfer time, the longer transfer time. So this is one case example. This is a case that I did in March 2024, 49 years old male, stable angina, 60% EF, and got non-significant lesion in RCA. As you can see, this patient got stenosis in mid and distal LAD, and also stenosis in distal LCX, and also OCL to mid-intermediate. So the plan was to perform TS to LAD, the DCB to circ, and also DCB to ramus. So put 2 stents in LAD, then we deploy 1 MagicTouch sirolimus DCB and circ, and also firstly we put 1 DCB in ramus, but because of dissection that we're not comfortable living alone, so we did a bailout stenting with 2.5 times 38 millimeter TS, and this was the final result. The patient came back with chest pain and positive treadmill test. We did for the angio, and this was the evaluation. So this patient got a simple lesion in RCA, which we put another DCB, and we did just fine. But I just want to focus on the evaluation. So this is 15 months of follow-up. So the DS was patent, and also the DCB in circ, you cannot really tell anymore the lesion. So in this case, DCB equals the durability of stents in 15 months follow-up. So as a conclusion, the paclitaxel and sirolimus act on different phases of the cycle to inhibit cell proliferation. Paclitaxel will target SMC more, while sirolimus affects APC more, and also paclitaxel has more toxicity and broader cell range. In DS setting, sirolimus is linked to lower target vessel failure and restenosis rates. In DCB setting, paclitaxel has better pharmacodynamic properties for delivery, tissue penetration, and retention. And there is the role of excipients, which will act as a delivery system in DCBs, playing a crucial role. And their development could significantly impact our DCB future and outcomes. And the current limited meta-analysis shows that in general, the outcome is actually quite similar between paclitaxel and sirolimus-based DCB. So, and as last words, I will encourage us all to not trying to be a good DCB interventionist, but just rather be a good interventionist and use DCB as one of the tools in one of the options in our toolbox. So thank you for your attention.
Thank you very much, Dr. Wishnu. Very nice presentations. I'm I invite the panelists, whether you have comment or questions, please share with us.
Hello. May I start first?
Oh, okay.
Yeah, you can, please.
Okay. So thank you, Dr. Wishnu Aditya, for such a great presentation and very wonderful case presentation. So yeah, I think we all agree right now that DCB has an important part in our strategy for the interventions. But maybe a couple of things that I want to ask you first about if we dealing with the CTO lesions. As we know, maybe the DCB approach in the CTO lesion would be like getting a value right now, as we know that the lesion in the CTO is undergo the chronic underflow states and also massive negative remodeling. As if we use the DCB, I think we can give the possibility of the vessels to grow even more and also to regain the functional itself. So what do you think in terms of if we can pass the wire into the CTO lesion, and but we met several subintimal space, maybe we go through the subintimal and then go to the through the to the intraplant again. What do you think? Do you prefer we can still apply the DCB in such situation, or maybe we can leave it with the only stent? That's the first thing. And the second thing is about the bifurcation of the simple bifurcation lesion. If we gonna apply the hybrid approach, as in the main branch we put the DES and the side branch we put the DCB. In terms of the Sirolimus DCB, as we know, the Sirolimus is really depend on the carrier itself. Is it really matter if we treat the side branch first and then we put the main branch stents later, or maybe it is we treat the main branch first and then later for the side part? As we know, maybe sometimes if we do the DCB later and if there's a pinching on the ostial, it would be like we're gonna put another balloon to open up again. Is it really affect the availability of the DCB in terms of Sirolimus on the wall of the side branch? That's all from mine. Thank you.
Thank you. Do you want to discuss between the panels, or I should answer that, Dr. Fauzi?
Yeah, please. Yeah.
So yeah, because we know that for all of your questions, actually we don't have any solid data yet. So everything that we answer is probably only a reflection of our personal opinion and our personal practice. If you're asking about CTO lesion, I think no problem with putting DCB as long as you have a good luminal gain and there is no tendency of restenosis after your pre-dilatation. But you made a very good question about what if you go subintimal, then probably you go true, false, true. In that case, I will probably not put a DCB. I would rather do a DS, and that will be my personal practice. And your second question is about bifurcation lesion and the hybrid approach. So I don't think it matters if you choose a Sirolimus or paclitaxel in this situation. And the consideration is not about the ostial lesion as far as I understand, but the composition of the lesion that you probably can understand well if you're doing intravascular imaging. If available, then you can see the composition of the plaque. For example, if the composition of the plaque is more complex, it's more calcified, and the fibrous is very thick, then I will probably choose paclitaxel. But if the lesion is simple and you can deliver it quickly, I will choose Sirolimus. And which one first, DS or DCB? In my personal practice, I will always put the DCB first before I stent, and therefore I do not need to go again to have to go passing a DCB through the stent route. And it will be my personal approach. Thank you.
Okay, thank you very much. Any comment from others? Dr. Cortese, any comment from you before we are having your presentations to start?
No, just a comment. This was a wonderful background which aimed to teach the physicians. So why we are doing that? So why are we applying a drug directly to the vessel wall, which is the phase that we need to intervene on, and why we don't need with a DCB to have a prolonged release of the drug, because we have to interact with the burst dose immediately to block the restenotic process. So that completely aligns with my knowledge about this technology. And then, of course, I will go through a few cases, and then we can go and discuss more about technical hints and tips and tricks with DCB angioplasty later, if you want.
Okay, I think we can continue your lecture, Dr. Cortese.
Okay.
Thank you very much, Dr. Wishnu.
Thank you.
So let me share it, and I'm really privileged to be here, unfortunately only from Ohio and not physically like we did, Fauci, as you were mentioning earlier, 2 years ago. It was a great experience, and I was really impressed. The first time for me in Indonesia, I was really impressed by the quality of the physician, the nurses, the cath labs that you can express. And I will be happy to accept your next invitation.
Great.
That said, so today I've been asked to present a MagicTouch coronary clinical program with a small deviation into the peripheral space in order to show the advantages of this technology. This technology is very important to me, and I'm very grateful because for several reasons. First of all, they came out in 2016 with the first Sirolimus coated balloon in Asia, 2015 and 2016 in Europe. I had a privilege to use the first cases at my institution in Milano and to run the clinical program of this device. And Sirolimus was really needed into this space, not because we don't need paclitaxel. We need paclitaxel. Paclitaxel coated balloons work well, but they are not perfect. So Sirolimus can complete the gamma of this technology in order to spare and reduce the overall stenting rate that is still very high in the world and in the US specifically, US where I work. And then the other thing is that this technology is really different. The deliverability of MagicTouch is unquestionable and is so superior to any other drug-coated balloon that is some complex interventions, and as a corollary also in a blended fashion to stents, like I will show in a few cases. And then the investment that the concept put into this field was very propedeutical also to other companies to invest into the field. And this is what we needed, because until 2015, only small companies with small studies, not investigator-driven studies, were trying to save this technology, which at that time was a really niche technology. So this is why I'm really grateful. I'm going to start showing a case that is again showing how a DCB angioplasty should be done and which are the advantages. So we have this gentleman with a stable angina, with this small minimal circumflex artery and this diffusely diseased LAD with a CTO of the right. So you can put a stent here. Technically, it's very easy. But my question is, would you do a good job to the patient with all of these big septal branches with these two huge diagonal branches? So don't be focalized on DCB, but just start preparing the lesion with semi-compliant balloons, a scoring balloon in the proximal part of the vessel we use at that time. And then you assess. Then you assess this. What do you think? Do you think this is a good lesion preparation? I think so. So now you can deliver the drug like we did in this case. We use a DCB in the diagonal branch 2, a DCB in prox LAD diagonal branch 1, and a DCB in the middle LAD. So 1, 2, 3 DCBs for obtaining this full revascularization. Still, there is this dissection, which is good for the drug. You assess it in an orthogonal view after a few minutes, and then you are done. And you will be happy to check the results a couple of months later when we wanted to tackle the CTO or the right coronary artery. This is an example on how a DCB angioplasty can ease your complex cases in order to spare too much metal. Of course, we needed to have more scientific relevance. This is why Patrick Serraius had the idea to gather all of the most experts in DCB in the world, and the DCB ARC was born. From this idea, we met several times during several meetings, and finally, we were able to come out with the first 2 publications this year in the European Journal and in JACC, trying to collect which is the scientific relevance of DCB now by 2025, and which are how we should plan the next studies, which are the correct endpoints to compare DCB one among the other and versus stents, and which are the areas where we need to explore this technology. So my suggestion is to go and read these 2 publications that we did. And one of the information that we got from this is that the learning curve is very important for DCB. We can start here from Piccoletto study that actually we did at my institution back in 2008 and 9, where we didn't know that we had to predilate the lesion. You can see that lesion predilatation was very low. And we knew at the time that we had to predilate stents, but not DCB, to be honest. And then the bailout stenting was so high. You can see here it was 35%. Then with the experience, we learned within the years that we had to predilate 100% of the cases, always before DCB, 100% of the cases. And we also learned on how to prepare the lesion. And then the rate of bailout stenting came down well below 10%. We have a big study. I'm not going to spend too much time on that. This study is the EASTBORNE. We published last year the 2-year follow-up of this. This is still the largest registry on the drug-coated balloons. It's a prospective registry in Asia and in Europe. We collected information from 2,123 patients at 38 centers. And with this study, all of the patients have been treated with MagicTouch. We show the safety and efficacy of this device in a broad all-comer population, okay? Broad all-comer population, showing how the TLR in the de novo at 2 years is very low, 3%. And the TLR in ISR, you can see here on the right part of this slide, is 14%, which is pretty good and probably better than first generation paclitaxel coated balloons in this setting. And this slide with the Kaplan-Meier curves is also showing how, in terms of TLR, there is a very small late catch-up phenomenon after year 1 in the ISR, whereas there is no late catch-up phenomenon in the TLR. This is also showing how we don't need to have a prolonged release of the drug with this technology. We need to have a good, efficient burst release at the beginning when we do the barotrauma, when we delay the lesion, but we don't need to have a prolonged release like we do with stents. I don't remember, to be honest, I don't remember the exact number of sub-analyses and sub-studies that have been published so far with EASTBORNE. They are between 25 and 30, but this is one that I wanted to bring you here. It's a sub-analysis in large vessels. So this is MagicTouch in large vessels. The mean reference vessel diameter was 3.2, and the mean lesion length was 22 millimeters. 181 were de novo, and 600 and more were ISR. And here you can see that the safety of this technology, especially for de novo, is very high. So this is not something that is related only to small vessels, but also to larger vessels. And then we presented last year, and it's currently under second revision. Hopefully it will get published soon, the Piccoletto 6 study. This is a mechanistic study that wanted to assess the and compare paclitaxel coated balloon and sirolimus coated balloon one with the other. We have 2 sirolimus coated balloon, we have MagicTouch, we have solution, and we have several types, 4 or 5 paclitaxel coated balloons. But the importance of this study, which is another investigator-driven study from my foundation, like EASTBORNE, was, these are not sponsorized study, I want to underline this, is that we wanted to enroll patients at experienced centers. And this is what we did. We only selected experienced centers, small vessel disease, and core lab and the assessment of the physiological performance and the angiographical performance of paclitaxel versus sirolimus coronal balloons. Here you can see that the lesion length is 23-24 millimeters, which is pretty good and much more than any other small vessel disease study addressed with this technology. Not surprisingly, paclitaxel coated balloon is better in terms of late lumen loss. From the angiographic perspective, paclitaxel will win because it has a lumen enlargement. Also, sirolimus has a lumen enlargement, but the one with paclitaxel is higher. Okay, so we have a late lumen loss of 0.10 with sirolimus coated balloon and a late lumen loss of minus, which is negative, 0.05 with paclitaxel. Positive remodeling, 58% versus 40%. But the primary endpoint of this study was the μFR during angiographic follow-up, μFR, assessed by a core lab. And the delta in μFR between the end of the PCI and the angiographic follow-up is very similar between sirolimus and paclitaxel coated balloon. So this goes into the same direction that we have shown in several studies, that if there is an advantage of paclitaxel in terms of angiographic performance, there is no advantage in terms of physiological performance, and there is no advantage in terms of clinical performance. I'm showing you another case that I did during one of my proctorships. This was in Serbia. This lady was a young lady with a stable angina, diffuse disease, okay, in the ramus and especially in the prox LAD. So we decided to use a full DCB angioplasty, to do a full DCB angioplasty here because of the big discrepancy between left main LAD and because of the trifurcation. So we started predilating, we used semi-compliant balloons, we used scoring balloon for the ostial LAD, and then we delivered sirolimus coated balloon in the ramus and in the LAD after having prepared the lesion correctly, as I just showed. And this is the final result. We have some type B dissection in the LAD, it's fine. We have this nasty dissection in the ramus, you can see here. We reassessed it after having dealt with the LAD angioplasty, which took us like 15 minutes. So after 15 minutes, we didn't have recoil, so we were happy about the result and we left it unstented. And this is the follow-up that the colleagues sent us after 4 months, showing the almost complete healing of the ramus, the very good result of the LAD, which does not have a lumen enlargement as we have with paclitaxel, but which constitutes a very good result with some restenosis in the distal part of the LAD, which was treated with POBA. So this is like in the same patient, a comparison between sirolimus coated balloon and POBA, showing that sirolimus coated balloon works better, actually. So, as I said, we have a few indirect comparisons. This is a case-based propensity matching Cox regression analysis comparison between paclitaxel and MagicTouch, showing at 1 year, and this study has been published on CCI this year, showing that at 1 year there is absolutely no differences in terms of any clinical endpoint. And we presented at EuroPCR this year the 2-year follow-up, not yet published, of this study, showing that there is no difference in terms of MACE in several types of patients between sirolimus coated balloon and paclitaxel at 2 years, with some advantage of sirolimus coated balloon in terms of TLR and TVR for this cohort of patients. And then, as I anticipated, sometimes we also have to give a look a little bit further from the heart. And this is why I'm presenting you the 2-year follow-up of this Sirona trial. Sirona trial is a multicentric, investigator-driven trial comparing paclitaxel coated balloon, which has a clear role for the SFA, to MagicTouch sirolimus coated balloon for the same vessel. And you can see here that at 1 year there was no difference, at 2 years there is no difference, but there is, if you can see the delta in sirolimus between year 1 and year 2, you can see that there are 2%, there is 2% or more events, 1.9, whereas in paclitaxel there is a plus 7% of events. So this curves start diverging, and we will see the 3-year follow-up if there will be a significant difference in favor of sirolimus. But this is again showing how the effect of DCB, if you are using a good DCB after lesion preparation, is maintained through the years. And Dr. Fauzi, I'm really happy to present here this case that I did when you invited me. I don't remember if this was done at your institution or in Jakarta. I remember that I just came from the airport after a very long flight.
Yeah.
I drank.
In Jakarta.
Oh, this was in Jakarta. Okay.
Jakarta, in Fatmawati Hospital.
Oh, yeah. That was an amazing hospital, an amazing cath lab, to be honest. But, you know, I came out from the airport with 2 Red Bulls to give me some good energy, because you presented me this case, which was very complex. This was an acute coronary syndrome gentleman with this calcific left main, diffuse disease in the LAD. And so what we did, we just started predilating. Then we did OCT. OCT showed us this calcification in the proxial LAD, this calcified nodule in the ostial LAD, and this severe calcification of the left main with a good, widely patent circumflex artery. So we decided to go with ROTA. We used a 175 burr, if I remember well, and then we started predilating the lesion. This is after lesion predilation. Okay, so anybody would argue that here we need to do something else. So we need to cover. Patients at this point started having a refractory angina. So we need to cover, we need to fix this. We need to put a stent. This is what we did. We put a stent, left main to the proximal LAD, okay? And then we reassess it again, okay? So we did the OCT showing how the stent was well expanded. So ROTA and predilatation, we also used a scoring balloon after ROTA did a good job. The circ was widely patent. Proxial LAD at the site of the calcified nodule was good. And we had this dissection this time. Look at this dissection. At that point, we had a discussion, a very nice discussion with the moderators. And I said, oh, with this data, with the good TIMI3 flow, with this dissection and a big lumen, we don't need to pave. We don't need to pave all of this with stents. Let's do just DCB. And we used a MagicTouch sirolimus coated balloon, a long one that was a 35, if I'm not wrong, that we placed there. And this is the final result. Again, a diffuse dissection, but the flow is good. The patient at that time was asymptomatic. So I insisted, in order not to treat with stents, also that part of the LAD. And I'm happy to say that we were right, because you sent me the angiographic follow-up after 3 or 4 months showing how the vessel completely or almost completely healed, and the patient was asymptomatic, and there was also myocardial bridging. So putting a stent there probably would have not been a good solution. And then a few studies, and I'm going to finish my presentation on the future. There was a question earlier about bifurcation. The future of bifurcation is not, if you prepare well the lesion, is not to reserve the DCB only for the side branch. In my opinion, we have to investigate the role of DCB, full DCB for bifurcation. And this is what we are doing with Picolet 5. Picolet 5 after lesion preparation is randomizing patient to stent, provisional stenting, versus full paclitaxel coated balloon, paclitaxel in both branches, versus full sirolimus coated balloon, sirolimus in both branches. We started the enrollment in this trial of 400 patients 2 months ago. If there is any of you in Indonesia which is interested to participate to this investigator-driven trial, please contact me, and we will be happy to see if we can activate also Indonesia. And then the big study with the MagicTouch is Transform 2. This is another international multi-center perspective investigator-driven study, which wants to assess the role and compare MagicTouch to Zion's stent in native vessel disease between 2 and 3.5 millimeters with long lesions. So maximum lesion length allowed is 50 millimeters. So this is a real world study that is willing to compare this technology to the gold standard drug-eluting stent in native vessel disease. We have randomized patients after lesion preparation, MagicTouch versus science, and we are doing the follow-up up to 5 years with a primary endpoint being assessed at 1 year, TLF, where we expect non-inferiority between MagicTouch and science, again, at 1 year. These are the centers that have participated enrolling patients. We also have Bangladesh, we have Brunei, we have Thailand on top, and Malaysia on top of European and South American centers. And I'm happy to present here the top 10 centers having enrolled patients, with UK that won over Bangladesh, that did a great job in enrolling patients for this study. And hopefully we will be able to have the primary endpoint being presented around June, July next year. That said, I'm done, and I will be happy to respond to your questions.
Thank you, Cortese. Fantastic presentations. So there are almost 200 participants. They are fans of you, Cortese. They are willing to hear from you, and of course from the panelists and Dr. Wishnu. And there are some questions from floor. I would like to read it. Regarding ISR, do the biological mechanism of these two agents have different roles, which is Limus and paclitaxel, from Dr. Dendi Wahyudi?
Yeah, so ISR actually is, to be honest, the Achilles heel of current interventional cardiology. In many cases, we have to deal with a mistake that has been done when the first stents have been implanted. So we have to, first of all, interpret them and understand which was the problem with that. That said, we don't have any direct comparison between paclitaxel and sirolimus balloons. We can say that, unfortunately, and you know, I want to be very honest with you. Unfortunately, the data that we have are showing that we still have 10 to 15% a recurrence of another ISR at 1 year, and 15 to 22% of recurrence of another ISR at 2 years, which is very high. If we go and see the performance of drug-eluting stents after intravascular imaging, I would say that their performance is better for ISR, to be honest.
Yeah, but sometimes in the bifurcations, ISR bifurcations, if you are putting the stent there and then the side branch, we will lose the side branch. That's why.
Yeah, I agree.
At this, yeah.
No, I use DCB as a first choice also because when you have 2 layers of stents, it's even more complex. But if we see the literature, if you're treating ISR in a normal cath lab, and if you don't use imaging, I think it's better to put another stent.
Okay, very good recommendations. Dr. Dasdo,
Yeah.
Anything you are going to comment?
Probably this will be very intriguing for us to discuss. You have already showed us the data comparing those two drugs and drug-coated balloons, and statistically not significant. Although you can see the tendency, it could have been better with the Limus, as you mentioned, 2% within 2 years' time. So could you elaborate which for which? I mean, in which case, as Dr. Wishnu has already showed us, it's just like for ACS, probably from his personal opinion, he would suggest for the usage of sirolimus-based DCB. And do you have any recommendations? Which kind of DCB to use in which setting?
Yeah, I agree with his previous answer. Usually, if we have a small vessel, a long lesion, I prefer to use paclitaxel because of the lumen enlargement. If we have some ectasia, I never use paclitaxel because, as you have shown, there is a higher risk of aneurysm, which is still low, but much higher than with Limus. If I do a CTO and I'm not sure I am within the lumen, I use only Sirolimus. I have nice cases of CTOs done with Sirolimus, and we presented Picoletto 10 at TCT this week, showing that using a DCB is completely safe to use any type of DCB for CTOs. But if I'm not sure I'm within the lumen, a direct release of paclitaxel to the adventitia or deeper into the media, I don't think is a good idea.
And may I know the percentage of the usage of intracoronary imaging in your practice when you want to use DCB?
Good question. So in my practice, I'm dealing with complex lesions. I don't do type A, B1, B2 lesions, to be honest. So my percent of intravascular imaging is around 75% to 80%, which is not as our colleague in Japan are used to do, but I know that they use it even more, but it's much higher than US or Europe. Specifically for DCB, I would say that you should use imaging in 50% of the cases. 50%. Of course, if you have a diagonal branch, if you have a simple lesion, you shouldn't use imaging. It's a waste of time. But if you have some calcification, if you have a complex bifurcation, if you have ISR, always use imaging. And I anticipate your next question. When shall we use imaging? I suggest to use imaging only upfront to understand the lesion. And I suggest to avoid doing imaging after DCB. In the case that we did with Dr. Fauzi in Jakarta, we did imaging at the beginning and during the PCI, but we didn't do after having applied Sirolimus. So you should avoid doing imaging after.
Thank you.
Okay.
Okay, Dr. Fauzi.
Rifqi, yeah, please.
Yes, thank you. Thank you very much. Very nice lecture, Dr. Cortese. I'd like to ask you questions regarding the combining effect of the effect of a combining drug at the tissue, in the tissue. For instance, like if we use like a paclitaxel drug-eluting stent, and then some dissection more than C class occur, and then or slow flow, and then we have to put a stent. And then we put the stent. I think nowadays we have all Limus stent. Is that any bad effect of combining, mixing Limus and paclitaxel in the tissue, like for instance, like ectasia or something else? That also might be happen in the nowadays. I think for bifurcation lesion, I think the hybrid approach for the professional stenting is now on the table to use. I think it's very interesting or very useful approach to simplify the complex lesion, not using a two stent but combining the stent at the main branch and then DCB at the side branch. But I think if we use a Limus stent in the main branch and then paclitaxel at the side branch, will it be a problem? How about the risks of the side effect of combined drug in the tissue? And then I think
no, my answer is already long. Could be wrong. So if you want, I can start and replying now, and then if you want to ask me anything else, I will be happy. So it's a good question. We wondered a lot of time, Dr. Rifqi, when and shall we use a drug-eluting stent? And this is why now we are accepting also type B dissection, sometimes type C, if we don't have recoiling, if we have a good flow. And in expert centers, the percent of bailout stenting should be between 5 and 7-8%. So why I'm saying that? Because some analysis of preliminary studies are showing that there is a slight increase of events in the arm where you put a stent, which is a Limus stent, as you said, after paclitaxel coated balloon. It's not, you shouldn't be worried. You should not be worried, but there is a slight increase in events. Okay, so this is something that we should try to avoid. This is not a big problem, to be honest, for the bifurcation. We have data now from the DCB-BIF and from another bifurcation study presented at TCT a few days ago, showing that if you use paclitaxel on the side branch, either you use it before or after, the two studies had a slight different design, there is no big issues. In the DCB-BIF, there is also a reduction in periprocedural MI, a reduction in periprocedural MI if you use paclitaxel versus POBA for the side branch. So for the bifurcation, I would say there is no specific concern. For long lesions, if you can avoid stenting, maybe it's better.
You have mentioned about avoiding intravascular imaging examination after balloon. What do you think if we use like a hybrid approach for bifurcation and then we put the balloon first at the side branch, and then after stenting, there is a recoil, like Dr. Dewa questions. And then should we redilate or just leave it alone?
Yeah, another important question, and with the technical consequences, and I'm happy to respond. Of course, I'm telling you my advice and my ideas. There is no general rule. I cannot say I am completely right, okay? But this derives from 20 years, almost 20 years of experience. So when you use a DCB for the side branch, I usually use it, I treat the side branch first, then I deal with the main vessel. I prefer not to do any kissing balloon, any distortion of the stent versus the side branch, okay? And the question is, how much would you like to accept for the side branch? Because you almost always have, or quite often you have a carina shift, okay? So what we have seen from previous studies, and to be honest, this information derives more from paclitaxel, you can accept also a 70% stenosis in the side branch. 70%. 70% is not associated with events. Some colleagues also accept a 90% stenosis. If I have more than 70% stenosis, after having applied the drug to the side branch, usually I go there with a small balloon. I try not to interfere with the stent and I inflate it slowly a little bit to arrive at 60, 70%. That's enough to keep the vessel open.
Thank you very much.
This is a lot of questions from the floors. One question is regarding physiologic testing. Should we use physiologic assessment post-DCB rather than just trust acute lumen gain angiographically?
So there is a paper under publication about that, because this is another frontier and interesting question. So FFR or derived measurements have been associated with good outcome if they tailor you in guiding you a DCB angioplasty. We have some preliminary data, but we don't have clinical trials. Whereas for the final assessment, I use physiology in less than 5% of the cases. Usually, the angiography is enough to tell you if you should leave the lesion, if you should go with another balloon. Sometimes you prepare the lesion well, you use the DCB, and then you have a worse outcome. Then you should be brave enough to gently predilating or using a scoring balloon at that point. But physiology, I use it very, very, very rarely after DCB because we don't have enough data, in my opinion.
Okay. How about the DCB in CKD from Dr. Dery Arara? DCB in CKD.
CKD, we are doing another study. It's a multi-center study, on the performance of DCB, several types of DCB in CKD, and we are also comparing sirolimus with paclitaxel. I cannot anticipate this. We will present at CRT next year, but what I can tell you is that it is completely safe to use a DCB in CKD, also because stents are associated with impaired outcomes. So we need to have an alternative to stents here.
Okay, another one, which you, there's a question regarding how about the future combined dual drug combination coated balloon? What do you think about it?
Yeah, with my foundation, we are following a company that has not patented yet, but has patented yet, but it doesn't have any CE mark or FDA mark, whatever, with this dual drug. I think it's a good technology. It's a good idea if you find the correct excipient. In this specific technology, there is a nanotechnology, which is a different technology, but same concept of Concept Medical MagicTouch to protect Limus and paclitaxel. The deal is to find the correct balance between these two drugs. With my foundation, we did a study in vitro showing that Limus is able to boost the effect of paclitaxel. So if you don't want to have aneurysms with this dual drug, the dosage of paclitaxel should be much, much lower than the one that we currently use with the drug-coated balloons.
Okay. Another question is about dissections. How you believe in dissected when you're going to stop? Because in Jakarta, there is a looks like huge dissections, but you are very convinced to leave it alone, and then the follow-up looks very beautiful. But other operator which has no much experience and concern about the abrupt occlusion. So what kind of recommendation regarding these things?
So if you are sufficiently experienced, there is no risk of occlusion with DCB. Myself, I had very few cases in all my life of acute occlusion. Of course, you need to start with DCB, I would say, with small vessels, with having good result. Don't fear to put a stent if you are not sure, but this is only the preliminary initial phase. After a few months, you will see that you can leave a dissection. What type of dissection should you leave? So you should leave a dissection if you have a good flow, if you have a good lumen of the vessel, and if you don't have recoil more than 40%, you should leave it and be safe that the patient will not come back with an acute occlusion.
Okay, thank you. Dr. Suma, are you going to have some comment regarding this?
Yeah, okay. Maybe some comment to Dr. Cortese.
Yeah.
So it's great to hear your presentation, your lecture, Dr. Cortese. It was insightful for me as well. So yeah, actually, I am going to ask back to the basic about the lesion preparation and the DCB strategy. Actually, not sometimes, I think we usually meet the significant recoil when we prepare the lesions. Do you have any tips and tricks how do we manage the recoil actually? Because do you believe in such a long balloon inflation time, maybe to overcome the recoil, or maybe you should switch the strategy using the scoring or maybe other balloon? Thanks.
Yeah, we are using scoring more and more, or cutting balloons more and more. There is a sub-analysis of wreckage free 1 study in China that is showing that the clinical outcome for DCB is better. So there is a significant difference versus for this DCB if you use a scoring balloon before DCB. And that's very important information. So we are using scoring more and more. We are using scoring mostly in moderately calcific lesions, in fibrotic lesions, in osteal lesions before applying DCB. Of course, if you have a severely calcified lesion, the scoring doesn't work, and so you should use a atherectomy. We have presented at TCT also another study on atherectomy or IVL before DCB, which is another safe combination of drug. You have to do whatever you can in order to prevent or treat recoil. And as you said, in a normal, not too complex lesion, if you have recoil, you should go with a longer balloon inflations to overcome this risk.
Can I raise one question, Dr. Fauzi?
Yes, please.
In the setting of STEMI.
Okay. Yes, Dr. Cortese, are you going to say something?
No, sorry, but then I have to leave after this question.
Okay, thank you.
In the setting of STEMI, with the evidence of thrombus in that lesion, during the acute phase, sometimes because of the vessel shrinkage, spasm, the vessel size doesn't reveal what the real thing is like. What do you think about the usage of DCB in such setting with evidence of thrombus?
Thrombus probably will hamper, if there is a lot of thrombus, will hamper the penetration of the drug. So what we try to do is to, since we have good data of DCB in a STEMI setting, we try to do some good lesion preparation with thrombus aspiration and predilatation. But if you still have a lot of thrombus, I don't think that DCB is a good idea.
Okay, thank you.
Okay, thank you very much, Dr. Cortese. You are going to have some other appointment. We are very thankful for your join with us in this webinar and insightful presentations. Thank you very much, and we
Thanks
hope
a lot.
that next our event you can come again and join with us in next our EasyCamp.
It will be a pleasure. Thanks a lot. Have a nice day.
Thank you, Dr. Cortese.
Yeah,
thanks.
Thank you very much. Okay, let's move on to discussions. There are some questions that you have to address regarding the the calcified nodule. Any faculty here have some sort of information regarding the role of DCB in the calcified nodule? Dr. Wishnu, please.
So I have seen any data yet about DCB role in calcified nodule, but personally, I don't think it actually. So the thing that we have to do in calcified nodule is to the proper atherectomy, if possible, because we have seen that with every modality available, it's still difficult. And it also depends on the angulation, like the wire bias and so on. So you can use IPL, ROTA, or OAS, or even the new lytics balloon. It depends on the situation. But you can use DCB, but in my opinion, only after a proper atherectomy if possible. Thanks.
Yes.
Or you can just do a DCB as a bailout, but there is no guarantee that it will work.
Yeah, this question is very important, and what your message is give us some insight. Actually, the question is focusing on eruptive calcium nodule, which is easy to reach stenosis. That's why even you are dilate the vessel using a very good dilatation, the stent is well expanded. There is some sort of high risk of the restenosis because the micro calcified protrude intra the strut stent. That's why nowadays they are thinking about using DCB, not because DCB is better than DES, but after DCB, if there is a restenosis again, we easy to treat compared with the using DES. That's why the latest case published by the Japanese colleague showed that after having eruptive calcium nodule, and they perform atherectomy, and there is stenosis, and they reperform atherectomy, and afterward the lesion is better and no restenosis anymore. That's why it is, I think, is going to be one of the option to treat eruptive calcified nodule. And thank you very much for Jordan Azari. You can join with the ECCAM and UP6 event. At that time, we are going to discuss about deep dive to calcified nodule. So don't forget to join during the ECCAM. And the other question is recommendation based on your experience about DCB role in infarct-related artery or STEMI cases. Any of the panelists? Maybe Dr. Dasdo can.
I would like to take a look on the.
Yeah, the role of DCB in the MI patient.
Yeah, I think I've done some cases. It's more than 10 using drug-coated balloon in STEMI cases. I think we'll be very dependent on the lesion itself, our comfort as the proceduralist. But one thing that I've done several times in STEMI, in the RAA, because if I'm not sure about the vessel size, and when there is discrepancy of the vessel size from the proximal to more the distal part, and it's somewhat challenging to choose a stent size, I will go with that coated balloon. And also in some young patients to whom I don't want to implant any stent, and there is chance for the patients to only be treated with drug-coated balloon once the pre-dilatation or preparation had been proper. So yeah, and I have done some risk studies to those patients, and it yields very good results.
Okay, how about Dr. Wishnu? In your daily practice, you use Limos DCB if you are wanted to use a DCB in the MI patient. Any justification for this?
Yeah. I will rather use a Limos DCB in ACS patient, and also to expand it more when the intravascular imaging shows it's a vulnerable plaque with a high thrombus, with high plaque contain high lipid composition. So I will use Limos balloon. And also from my personal experience, if you do it on simple lesion, then there is no subtle differences between using a Limos and Baghdad cell balloon.
Okay, yeah, I think one of the option, but have no recommendation about this, is using DCB in the acute coronary syndrome, because some of the patient with acute coronary syndrome will quite reluctant to put the stent when dealing with the bifurcation or very diffusely disease. At that time, we are willing to use a DCB. And there is some published paper from Dr. Anika and colleague that if you are using DCB paclitaxel cells, is going, there is the cases show the aneurysmatic. We don't know exactly whether this is related of the paclitaxel itself or because of the mechanism of acute coronary syndromes. Because some acute coronary syndrome have dissected until the media, but the other part is just erosions. So at that point, we don't have any data whether Limos or paclitaxel in the acute coronary setting. Yeah. The other question is Gary Walfaldi. Hello, I have a question regarding practical application, aggressive pre-dilatation before using drug-coated balloon, with specific intent of creating medial dissection, which potentially enhancing DCB efficacy. My question, which focus more on practical clinical aspect. In your extensive clinical experience, how frequently in which specific scenario can actually apply this strategy? Aggressive lesion preparations. How, Dr. Vishnu?
So the intent is actually to make only enough dissection to cross the line. So for example, it will be best if you can make a multiple micro dissections and also intimal dissection, but not more than media. If you, there's actually a very limited data if you want to dilate it until the media, because if you go up until the media and also you will disrupt the EEL, then probably you will disrupt the overall integrity of the vessel. So therefore, if you want to do an aggressive dissection, you don't need to aim at the media dissection, but you need to have a good open area of the fibrous plug probably. In this case, probably you will have a very thick fibrous plug. So that's where the role of specialized balloon like scoring or cutting shines actually. It can make a deep dissection, but it can save lots of soft tissue. So I don't think that you should aim for a medial dissection. Probably you have another opinion, Dr. Fauzi, on this.
Yeah. There is some debate about this, but other published papers show that if you go to until the media, there is some sort of what it called is therapeutic dissection, because it again penetrated the drug to the media, which is very important. But if you have such huge very dissection in the media side, and there is going to be aneurysmatic. So we don't know exactly how the sweet spot, how huge you are going to dissect the media. There is some report about it, about the OCT finding of the media in the using OCT to find out the dissected media with the DCB angioplasty. Yeah.
If I can
okay. Yeah, please, Dr. Dasdo.
Share some more comment. I think a dissection is still a dissection. And of course, we know we need dissection in order for the drug to penetrate better. But somewhat it will also cause some discomfort for us. We know type B dissection is okay, but to really aggressively dissect the vessel and intendedly, I'm not sure. And of course, it's very. How can we know that we goes into the intimal or we go into the medial part? I think the discussion will just go into more research point of view. We're going to be more scientific, but talking about practical issues, it will be very challenging for us to get to know where we have gone.
Yeah, the Japanese colleague published in the TCT Nature study, which describe using intracoronary imaging in the DCB angioplasty, and then they're going to have some impact on the how DCB work, especially when it is dissected with the media. The Nature study, but still have some. They still there are still numbers of patients waiting to have the data. They still part of the data already published in the TCT. But we need more data regarding this kind of situations. Okay, we are close to the time. Thank you very much to all our speakers and panelists for your insightful presentations and valuable discussion. This has been excellent session highlighting the clinical value, especially we heard from Dr. Wishnu, from Dr. Cortese regarding the clinical value of sirolimus coated balloon and the importance of careful lesson preparation and thoughtful patient and lesson selection to achieve optimal result. We hope today discussion expand our perspective on how DCB technology, especially Limus-based platform, can play a key role in contemporary PCA practice, particularly in complex coronary disease scenario. To all participants, thank you for your active engagement. We'll look forward to seeing you again in ICCAM in next week, and then our next ISIC distance learning session. Wishing everyone a productive evening and continued success in your practice. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih semua.
Ya, terima kasih semua.